Okay, so why don't we start now talking about the evidence base for habit reversal and the evidence base for what we call CBIT, or the Comprehensive Behavioral Intervention for Tics, which is habit reversal plus the function-based treatments that we talked about. So we'll talk about that in the history. Let's start with habit reversal. What do we know about habit reversal and its efficacy? Habit reversal training, or HRT, has been studied now for almost 40 years at this point using single subject and group experimental designs. Okay, so large body of literature on habit reversal. More literature on habit reversal than any other treatment for Tourette's, by far. It's considered, according to APA Division 12 criteria, to be a well-established intervention for adults with Tourette syndrome. Okay. Cook and Blocher, a review in 2007, suggested that. To date, actually before 2010, 6 randomized controlled trials had been conducted on habit reversal for Tourette syndrome, and the sample sizes in these studies, these 6 randomized controlled trials, have ranged from 10 to 42 subjects, which are relatively small trials, but in the scope of Tourette's research, this is pretty much what most drug trials look like. Drug trials for Tourette's pretty much fall in the 10 to 42 sample range. In these trials, in the research on Tourette's for HRT, adults and children have been studied, mostly adults. Okay, in the larger trials. The children have pretty much been studied in the single subject experimental design type studies. The controls that have been employed for habit reversal, looking at habit reversal, have been weightless control, which normally is a fairly weak control for testing the efficacy of an intervention, but for Tourette's it's essential. Given the nature of the disorder, because of the waxing and waning, if you haven't established a weightless control, you've not ruled out improvement over weightless control, you haven't ruled out a very essential confound, which is the natural fluctuation of the syndrome. But habit reversal has always beat weightless control in intervention. Supportive therapy, in the small pilot trials, habit reversal has beat supportive therapy in adults with Tourette's. And another behavioral treatment, habit reversal has been tested against 2 behavioral treatments. One, habit reversal was tested against mass negative practice by Azrin himself and shown to be more effective than mass negative practice, which wasn't effective. And another study by Verdellen et al. Out of the Netherlands looking at habit reversal versus exposure and response prevention. And in that study, habit reversal showed no differentiation between it and exposure and response prevention, meaning both treatments worked equally well. Now that could be because they're both dealing with similar mechanism, habituation to the premonitory urge. That's a possible explanation. But there's a confound that doesn't allow us to use that interpretation, because the Verdellen et al. Study, actually, if you read the paper carefully, the same number of treatment sessions were used in habit reversal and exposure and response prevention, but the ERP sessions were actually twice as long as the habit reversal sessions. So there's also an amount of treatment, like a dose of treatment confound there that was higher in the ERP condition. So it might be a mechanism explanation, it might be a dose explanation. All of the results, other than the exposure and response prevention study, have shown a separation from waitlist or supportive therapy. Okay. We'll talk about that a little bit later. If this is the case, if habit reversal has been around for almost 40 years, and it's got good evidence behind it, and Division 12 criteria are met for well-established intervention, at least for adults, why is it then that in the psychiatric community and in the neurological community, habit reversal is a new thing? I mean, I do a lot of talks to these groups, and none of them have heard of habit reversal before. Most behavior therapists in training have heard about this at some level. But for the medical community, this is a completely novel intervention. I mean, I always am very, when I do talks, I'm always very deferential to Azrin, saying, you know, he actually did a lot of this. It wasn't us. Our group wasn't the creator of this. Why is that? Why did that happen? I think it happened because psychologists are very bad self-promoters, historically. And I think psychologists are very good about talking to themselves, especially behavioral psychologists are very good about talking to themselves but not communicating to the broader audience. And what do I mean by that? If you look at where most of the articles that were done about Tourette's, behavior therapy for Tourette's, look at where they're published, they were almost all entirely published in behavior therapy journals or behavior analysis journals. That's where they sit. Let's look at behavior analysis journals. Behavioral psychologists don't even read behavior analysis journals. The Journal of Applied Behavior Analysis is one of the least cited and least read publications among behavior therapists. Okay? So that's where a lot of this stuff came out. Most physicians do not read behavior therapy. Most physicians do not read the journal Behavior Research and Therapy. That's where a lot of this stuff was published. Except the problem is that all the treatment is originating out of neurologist's office and psychiatrist's office. So they have no way or reason to know that this stuff would ever exist. Right? So that's one of the big problems. The other problem with communicating this information has been the conferences we go to. Most psychologists do not make a point of heading to the American Neurological Association meetings. They don't make a point of heading to the American Psychiatric Association meetings. They'll go to the American Psychological Association meetings, maybe, and most of the time they do more specialty conferences. And so there's just no reason that a lot of these paths would cross. Right? The other problem is that the way we've done studies have not been taken terribly seriously by the medical community. So single subject experimental designs, which I understand as a behavioral psychologist are extraordinarily internally valid designs, are case studies to a physician. They don't understand the nuance of a single subject experimental design versus a case study. So a lot of the early work in this was all single subject experimental designs, and the physicians who do happen to come across these think, oh, that's cute, they did a case study showing that this works, there's no validity there. And so there's an interpretation problem. The larger group studies that we've done have all used methods that they're not necessarily familiar with in terms of assessment. Physicians very rarely, in the medical community doing drug research, will very rarely do direct observation of tics when they study Tourette's. That doesn't even seem valid to them, which is a little odd, but it doesn't make sense to them. So we did a lot of methodological things in testing behavior therapy that weren't landing well with the medical community. Either they weren't contacting it or we were doing methodological things that they weren't familiar with. So this brings us to this slide. The Tourette Syndrome Association is a patient organization that started in the 70s, early 70s in New York. Now it's a national US-based organization, but they really are kind of like the leaders in the world for Tourette syndrome advocacy and education. They're a patient organization, so they're responsive to the needs of their patients. In the early 2000s, they were getting a lot of feedback from their constituents, asking for alternative treatments to medication for Tourette syndrome. They had all tried the medications. New medications weren't coming out. If they were just repackaged versions of old medications with the same problems. And the membership wanted something different. So they went to the Tourette's Association and said, is there anything new coming out? And so the Tourette's Association brought together a group of people that they had learned were doing stuff in behavior therapy for Tourette's. And the group of people are up here. Some of them were true behavior therapy people. Some were people who were just leaders in the Tourette's field who were familiar with behavior therapy but had other experiences that were very helpful. They brought a group of us together, John Pasantini, John Walkup, who's a psychiatrist now at Cornell, he was at Hopkins at the time, myself, Sabina Wilhelm, who's an adult psychologist at Mass General, Larry Scahill, who's a nurse at Yale Child Study Center, which is sort of the epicenter of Tourette's research, and then Alan Peterson, who's actually a student of Azrin in the late 80s, early 90s, who is at the University of Texas Health Sciences Center. Brought us all together and locked us in a room at the LaGuardia Marriott. If you've ever been to the LaGuardia Marriott, you know that you really want to be out of the LaGuardia Marriott as quickly as you can be. And they told us, come up with something. You can come out when you have something for us. Tell us what to do next in terms of behavior therapy. So we sat down and we really looked at it. We all knew habit reversal had to be at the core of it. There was too much evidence to ignore, and it didn't make sense to try to start over when habit reversal already had a good bunch of evidence behind it. But we also felt that habit reversal probably didn't go far enough because it didn't address all the other environmental factors. It didn't address those functional pieces to the effects of the environment on tics. So we decided to create a new package of intervention, and we created something called the Comprehensive Behavioral Intervention for Tics, or CBIT, which we later found out was also some cocaine addiction treatment, which was unfortunate for us, but we spent half a day coming up with an acronym, so we just left it at that. So we created this thing called the Comprehensive Behavioral Intervention for Tics, which is essentially habit reversal, plus this function-based intervention, plus psychoeducation about Tourette's, plus a relaxation component to deal with stress. So there's a host of different things in there. We decided that would be our intervention, but we also decided that if behavior therapy was ever going to be taken seriously by the medical establishment as a treatment for Tourette's, we had to do things a little bit differently than we'd done them before. First of all, we had to gear this whole treatment study, the studies that we're going to propose, we had to gear them to the medical community. So we designed them with the intention of publishing them in a medical journal. So we didn't design them with the intention of publishing them in a psychology journal. Second of all, and that's where Dr. Scahill and Walkup helped, because that's where they live, in the medical community. So we designed with that idea in mind. We also designed big. We thought if we're going to be taken seriously, we need to do studies that have the sample size that the medical community can't ignore. And so we actually designed what are the largest studies ever, largest treatment studies ever in Tourette syndrome. Medical, non-medical, it didn't matter. These were the largest studies ever in Tourette syndrome, where tics were the particular target of treatment. We decided to do parallel studies, one for children, one for adults, and we did them essentially at the same time, although the adult study started a year later. We had the exact same treatment guide that we used, although it was developed in age appropriateness. And I thought the Tourette's Association was going to send the manuals, because they have hundreds of these things that they give out for free, but they didn't, obviously, which is unfortunate, because I was just going to give everybody a copy of it. But they sent a lot of other stuff that you can have for free when you leave, or whenever. So we proposed these two studies, and we were going to have, they were all multi-site studies. In the child study, the top 3 sites, UCLA, Hopkins, and myself, collected the subjects on the child side. And the bottom 3 sites were the data collection centers for the adult sites. And all 6 sites played a role in both studies. So that it's important to understand that. We applied for and received, these were back in the good old days when there actually was money to apply for and receive. But we applied for and received 2 4-year NIH grants, R01s. Each were worth about $3 million. In fact, the child study, we hit on round 1, which just never happens. It was kind of shocking. So I said, those were the good old days. Those days are gone, you know. This is the design that we used for both of these. They're the same design. Baseline assessment. Assessments were conducted by a blinded independent evaluators. Didn't know which treatment arm the person was in. Baseline assessment at week 0, a midpoint assessment, and a 10-week assessment. At the end and treatment for both conditions were 8 sessions over 10 weeks, 6 sessions weekly, and then every other week through session 8. At the end of week 10, people classified as responders, which we defined as a CGI score, Clinical Global Impression score of 1 or 2, very much improved or much improved. CGI responders were sent into once-a-month booster sessions for 3 months. Non-responders were no longer followed. They just kind of went into space. At the end of 3 months, we reassessed. That's week 23. And then they went into open follow-up into week 36. No more treatment. So 6-month follow-up from end of treatment. The treatment components, as I said, CBIT, or the Comprehensive Behavioral Intervention for Tics, psychoeducation, habit reversal, functional intervention, relaxation training, and reward component. The reward system was essentially a motivational component for the child. It wasn't a reward for tic reduction. It was a reward for coming to session, doing your homework, participating in session, those kinds of things. It wasn't a big part of treatment, actually. And then the psychoeducation and supportive therapy piece was general supportive therapy for living with Tourette syndrome. And it was covering different topics about psychoeducation week to week and talking about how that particular issue played out in the life of the child. Both sessions were conducted, at least for the child study, both sessions were conducted, all sessions were conducted with parent and the child in the room for the most part. As the child got older, or as sessions continued, sometimes the parents would leave for parts of sessions. Eligibility criteria for the child study. I'm only going to talk about the child study today. The adult study actually isn't published yet, but results were similar. Age 9 to 17 for children, and for adult study it was over 16. The people who were in the study had to have a primary diagnosis of Tourette Syndrome or chronic tic disorder. They had to have a CGI severity score of greater than 3 and a YGTSS, which is a Yale Global Tic Severity Scale, which is a 0 to 50 point scale, with 0 meaning basically no tics, 50 meaning extraordinarily severe tics. YGTSS score had to be greater than 14. They had to be unmedicated or on stable medication for at least 6 weeks with no planned changes. Right? So this actually works against us. In most drug trials, they have a washout period where they're on no active medications for the condition they're being treated for. Here we actually let them be on medications, and 40% of them were on medications for tics, as long as they were on a stable dose entering the study and they had no changes throughout. So this actually worked against us in terms of improvement. But we felt that if we didn't do that, we wouldn't be able to recruit enough, so we let them in. We had to have patients who spoke English and had informed consent. Exclusion criteria: if the subjects had a YGTSS score of greater than 30, that meant they had a pretty serious case of Tourette's. And we wanted to exclude them initially just to make sure that they understood all the different treatment options that they had in front of them. So if somebody had over 30, they were initially not eligible. We sat down and we talked with them. We said, look, we want to make sure you have a pretty serious case. We're going to talk with our team and make sure that we've reviewed your case, you've been exposed to all the treatment options, you know what's happening. And if we still think it's appropriate for you to come in and you still want to after being informed of all your treatment options, then we'll let you in. So we did let the more serious cases in. We had 15 cases who had a YGTSS over 30, and I think maybe 3 or 4 weren't approved for severity reasons or chose to go do another treatment. IQ less than 80 were excluded. This is on the WASI. And a CGI severity of less than 3 were excluded. Anybody who had excessive or problematic substance use or chemical dependency in the past 3 months were ruled out. If you had a lifetime diagnosis of autism, another pervasive developmental disability, mania, or psychosis, you were out. If you had any other serious medical or psychiatric illness that required more immediate attention than the tics, then you needed to get that treated first. So if a person came in and they had Tourette's, but they were also suicidal and depressed, it's time to go get that dealt with before you come in. Or a person had crippling OCD that was much more impactful than the tics, and they had to go get that dealt with before we would have let them into the study. They also, if they had previous treatment with habit reversal, 4 or more sessions, they were excluded. Nobody did because nobody has access to this treatment. This is our consort diagram, our flow. 177 were consented and screened. 126 were ultimately randomized. 61 to CBIT, 65 to supportive therapy. Now the important part here is this number, 6 and 7. Those are your dropouts. Now the reason that's important is because dropout rate is an indicator of treatment acceptability. Okay? And what this tells us is that both supportive therapy and CBIT were actually pretty acceptable. People like doing it. 10% dropout rate is really low. When you look at, like I said, Haldol for Tourette's, the dropout rates reported in those studies approach 80%. So you see a differential response in terms of acceptability. We'll talk about the long-term outcomes a little bit later. The sample characteristics. Mean age, about 12, roughly. Mostly male, like we'd expect. Average IQ, I think the WASI tends to overestimate IQ anyway, so this is probably, they look a little high, but I'd say they're right at about 100 in real IQ term. About 40% were on tic-reducing medications. And there are no differences, by the way, between sample sizes here, or between samples here. 2-parent family, pretty stable group, and fairly professional family. terms of other diagnoses, most of these kids were had Tourette diagnoses. A few had chronic tics, and a few had chronic vocal tics. One did, actually. Other diagnoses, again, the most common comorbid diagnosis was ADHD, somewhere around 25% of the whole sample. Again, I think this might be a little low, but I don't think it's that far off of what the real Tourette community-based population of Tourette's is. I think what we ended up getting here are people who would normally never bother to go to a psychiatrist or neurologist because they don't want to medicate their kids. So we end up getting those people who have Tourette's that are just as severe as the other the groups that have been reported in prior data, but they're also kids who don't have a lot of other things. And I think we collected a different sample of kids with Tourette's. One I think that's probably more well represented in the general Tourette's community. That's just my hunch. ADHD though was relatively low for Tourette's populations, but high obviously than the base rate for ADHD. OCD, same thing. Again, much higher than the general prevalence rate of about 1, but a little bit lower than what you've seen reported in some previous studies on Tourette's. What struck us, though, and this is through a structured diagnostic interview, which a lot of other characterization studies in Tourette's haven't used, so that might be another difference. But one of the things that struck us was the higher level of anxiety disorders that showed up in this population. So especially the social phobia. We saw social phobia occur at rates that were a little bit higher than what we've normally seen published in Tourette's samples. So I think that's something to pay attention to. Primary outcome measures. So primary outcome measures, we use 3. The CGI, the Clinical Global Impressions Improvement Scale, which is a 1 to 7 rater-initiated scale. Score of 1 means very much improved from baseline, 2 means much improved from baseline, 3 means improved from baseline, 4 means no change, 5 means a little worse, 6 is much worse, 7 is very much worse. So those are your anchors. YGTSS, the Tics score portion of it, which is a 0 to 50 point scale. And then the YGTSS also has an impairment scale on it, which is how much are your tics impairing your life on a 0 to 50 point scale. 0 meaning no impairment, 50 meaning great impairment. Here are our results on the CGI. This is the percent of children who are responders after 8 sessions of treatment, so at week 10. 53% of the CBIT group are treatment responders, meaning they have a CGI of 1 or 2, meaning they were very much improved or much improved following 8 weeks of treatment. 19% of supportive therapy people were responders. This is significant. If you add in a CGI of 3, like the score of did you get better, was there any improvement, then about 75% of the sample showed at least some improvement following treatment. Okay, so one child actually got worse as a result of CBIT or after CBIT. That was a kid I treated, and I know what happened, and it really didn't have anything to do with her getting worse. She was actually getting a lot better until something happened right before she did her final assessment that kind of blew her tics up, and it looked a lot worse than it really was on that last day, but whatever. Now, in terms of medication status, we looked at medication as a moderator. So did med status affect outcome? And the answer, if you're hard and fast on your stats, is no. Technically, meds did not moderate outcome, but the p-value was 0.07. So we were probably underpowered to really detect it, and it was trending in the direction of meds affecting outcome in a negative way. So essentially what the trends were showing was that when a person was on a tic-reducing medication, they did not respond as well to CBIT as they did when they were off medication. Now, the reasons for that are unclear. There are a couple different explanations that could be out there. One possibility is that when a person comes in on medication, you can assume that the medication was there for a reason. In other words, they had higher level of symptoms, they took the medication, and it reduced symptoms. So it could have been the case that the people on meds had hit a floor. They weren't getting any lower. The meds had done all that could be done for this condition. There was not getting any better for this child. And so in that case, if that's the explanation, then the meds have done the work, and behavior therapy doesn't add anything. That's one possible explanation. We don't know if that's true, but that's a possible explanation. Another possible explanation, which we haven't explored yet because we're still thinking through it, we just haven't pulled out the data, is that this effect may depend on the type of medication that the child is taking. Why do I say that? Well, the two most common classes of medication are the alpha-2 adrenergic agonists, like clonidine or guanfacine. That's one class. And the second is risperidol, atypical antipsychotics. Now, if you go into the literature on basic operant learning and look at the effects of atypical antipsychotic medication on reinforcement learning, basically what happens is it messes it up. When you're on atypical antipsychotics, people don't respond to reinforcement contingencies the way they should. They don't respond as efficiently as they should. Reinforcement learning takes a hit when you're on atypical antipsychotics. So if we're relying on operant processes for behavior therapy for Tourette's to work, and we're giving them a medication that affects operant processes in a negative way, we're setting ourselves up to fail. Much like you'd be setting yourself up to fail if you gave Xanax to people who are in treatment for, social phobia, and you're trying to treat social phobia through CBT, and you give them, anti-anxiety agents to take as they get anxious. It kind of blows up the point of the treatment. And so we might be having the same issue here. We don't know for sure whether that's the case, but that's something definitely worth exploring. Okay, what about other symptom reduction measures? The YGTSS. Significant reduction in tic severity for CBIT relative to supportive therapy at the end of week 10. Med status, again, didn't moderate, but was close to moderating outcome. Impairment was significantly reduced for CBIT relative to supportive therapy at the end of 10 weeks. Again, med status didn't moderate outcome, but it was close. Now here's the other part. Where CBIT, or behavior therapy, HRT, for Tourette's has ever gotten attention in the medical community, it's been negative attention. Like the question of why would you ever consider doing this for somebody with Tourette's? This is borderline cruel. If you look at some of the medical writings in the 80s and early 90s about this, that's really kind of the impression, like this is not a good idea, essentially. When it does work, it doesn't last. That's one of the criticisms. Essentially, that behavior therapy for Tourette's is a parlor trick that is just a short-term, in the session fix, but as soon as they leave the session, it goes away, kind of thing. And you can read that and hear some of that in some of the early writings in the medical community from this. So we tested this. We tested a 6-month follow-up period, actually 3 and 6-month follow-up period. The supportive therapy, we couldn't do because we lost randomization because we didn't include non-responders. We couldn't do a head-to-head comparison at 3 and 6 months because we lost the randomization. But we wanted to look just within each group, how well did people maintain their gains. So really what we're most interested in here, since the sample is adequate, is the CBIT condition, or the light blue columns. And what we found is essentially at 3 months follow-up, 3 months after treatment had ended, 86% of the people who had been responders to CBIT at the end of 10 weeks were still responders 3 months later. Okay. If you go 6 months later, 87% of people who were responders that we were able to find, who were responders at the end of treatment, were still responders 6 months later. What this tells us is that once you get better, you stay better for the most part. We also looked at other long-term follow-up data. So what happens to YGTSS severity scores? Well, for people who responded, their severity scores stayed down. So they were still down 3 months and 6 months later. Now this was true for supportive therapy as well, but we're most interested in CBIT at this point because we've established primary efficacy of that intervention at 10 weeks. We also know impairment was down. Once you responded to CBIT, your tic-related impairment stayed down 6 months later. Now, let's talk about how, if we can, how CBIT stacks up to other common interventions for Tourette's. Now, we didn't do a head-to-head comparison between CBIT and medication, so take this with a big grain of salt. But let's just look at how CBIT performs relative to a few metrics compared to atypical antipsychotics, like risperidone and geodone. These are the two studies, the risperidone and ziprasidone studies, are kind of like the big studies that established those drugs as effective for Tourette's. Okay, so they're the most well-designed trials, or the best trials for these. Think of it that way. And we compare them on a couple different features. Sample size, our CBIT study, which actually was published our goal was accomplished. We published it in JAMA in 2010. So it came out in May of 2010 in the Journal of the American Medical Association. And I think it would have gotten into the New England Journal of Medicine if it weren't for one, I'm pretty sure, neurologist who came up with a bunch of bad arguments about our study that we didn't get a chance to respond to. I'm a little bitter about that, but needless to say, it came out in JAMA, and it was 126 subjects in our study versus 34 in the risperidone study and 28 in the ziprasidone study. So our sample size was quadruple of what some of the drug trials that are commonly used to support the use of medications for Tourette's. Our control group was supportive therapy versus pill placebos. Our reduction in YGTSS scores, which is our severity, was 31% reduction relative to 36% in the risperidone and 35% in ziprasidone. We're in the ballpark of what these atypical antipsychotics produce. Our comparison group was actually more active than the pill placebo group. So our comparison group actually probably was an effective intervention. I mean, it wasn't as effective as CBIT, but it did have some sort of real effect there, beating just typical pill placebo. I think that resulted in the reduction of our effect size relative to the drug trial. So our effect size, which was about 0.7, which is respectable, was a little lower than a 1 and a 0.9 for risperidone and ziprasidone. But again, that was probably brought about by the fact that our control group was actually more powerful and probably wasn't an inert control. So what does this tell us? This tells us that CBIT, behavioral intervention, is in the ballpark of an atypical antipsychotic in terms of what it can produce, in terms of tic reduction. Now, we did something else that was a little unique for a psychosocial trial in that we measured adverse events, just like you would do in a drug trial. So every week we went through adverse events checklist to make sure that any new problems that cropped up we documented and treated it just like a drug trial. And we asked about all kinds of, in fact, we pulled it right out of a drug trial, and that's why you see some weird things up here that you wouldn't normally expect. And what you're looking for when you look for adverse events that you are trying to say are specific to a treatment, you're comparing the occurrence of adverse events across treatments. And you're trying to see if there's a differential occurrence of the adverse event in one condition versus another. And if there is, then you say that there's an adverse event associated with this particular treatment. We found, of all the things we looked at, we found 2 adverse events that seem to be relevant or differentially occurring between conditions. Accidental injuries were happening much more often in the control group, and stomach discomfort were happening much more often in the control group. Our conclusion was that psychoeducation and supportive therapy makes you prone to injury and sick to your stomach. I'm kidding. Obviously, we didn't conclude that. That wouldn't be very PC now, would it? No, really the problem here is that there are multiple comparisons that we didn't correct for statistically. You know, if you do a Bonferroni correction for multiple comparisons, all these things go away and there is no differentiation between group. We also looked at a couple other things. Again, if you go back into the literature looking at the criticisms of behavior therapy for Tourette's, you'll find a lot of statements made about bad things that behavior therapy for Tourette's will do. So, asking a kid to suppress his tics, which is what behavior therapy does, kind of, not really, but that's what the criticism is. Asking a kid to suppress his tics will just make him anxious and nervous. It'll stress him out too much. He'll just get really anxious because he's doing that. It'll also make him very upset and angry. He'll get really disruptive because you're asking him to do that, and it'll really cause family disruption. It'll actually make his tics worse. When you try to stop your tics, it just makes it worse. And it's such a hard thing to do, to watch your tics all the time and focus on trying to stop them. You'll just wear them out. They'll get tired and they'll get fatigued really badly. Okay? So those are the criticisms you can find in the literature. And we looked at those. Do those actually happen? And the answer is no, they don't. And they don't happen differentially between groups either. And so really those side effects, those that have been proposed, they're just not there. So, if behavior therapy for tics is so promising, why isn't it out there more? I've addressed this a little bit before. Well, first of all is dissemination. How do we train people to do this? How do we teach people to do an effective treatment? I think that somebody trained in behavior therapy could read a manual, get some supervision, and fairly quickly pick this up. If you're an anxiety OCD person, you pick it up even faster because you're trained to kind of think like this. So I think that's the case. Most of the world, though, is not that. They're not behaviorally trained psychologists who will read a manual and get supervision. How do we do this? How do we get these treatments out to people in a way that can be most effective? So that's a question. We have to figure that out. What we're doing here is a great way to start. This is a wonderful, wonderful thing. This will make it accessible to people and teach them to where to go for additional training. Referral problem. Neurologists, pediatricians, sometimes psychiatrists, but actually mostly neurologists and pediatricians are the first people to see these kids. If they don't know we exist, we don't exist. And so we need to figure out how to communicate what we have to those folks. A neurologist friend of mine was doing a talk at the American Academy of Movement Disorders or Movement Disorder Society or something like that. And he told me a little story that I thought was really interesting. And it goes to show back to the issue of where you publish makes a difference. He did a talk I think it was March, and told me the story. He said, I was at this movement disorder society with a whole bunch of movement disorder specialists doing work in Tourette's and so on. And they're all neurologists. And he said, I asked him a question because I was talking about updates on treatment. He said, I asked him a question. I said, how many of you have heard of CBIT, Behavior Therapy for Tourette's? And he said, out of a room of about 30, he said about 20 raised their hand. And he said, how many of you have heard about that before the JAMA article came out? And maybe 2 of them had kept their hands up. So it shows that that kind of thing, that one publication makes a huge difference in where you publish. And then he said, how many of you have actually referred because you've heard of this now, referred people for this? And 5 or 6 hands stayed up, which it was really powerful to me to think about this. A treatment that had been around essentially for 40 years would have gotten no hands going up. One article in the right place sends a third of the room, changes practice. And that's a really kind of powerful thing to think about. How do we get this out to other people? One of the things we've been doing is looking at where else we can train people to do this. So I do talks like this a lot. I probably travel 20, 25 times a year to pediatrics conferences, psychiatry conferences. Most of the talks I do are to medical community because we want to tell them about this stuff and let them know that it exists. Creates a problem because then we have to create referral sources and we don't have anybody who's trained in this terribly well, so that's another issue. The other thing to think about of why, if behavior therapy is so promising, why isn't it out there more, is we have to be sensitive to the history of psychology's role in the treatment of Tourette's. If you ask somebody who's 50 years old who has Tourette's what it was like for them growing up in terms of getting treatment, they're going to tell you it was hellish. They're going to say, yeah, I went to a psychologist, told me my mom had caused this and that it was my fault that I couldn't stop it. Yeah, that's what I think of as psychology. That was great. And they're really bitter about this because they were trained by sort of an analytically informed group who viewed the syndrome as a very different thing the way we view it today. And the idea that psychology should have anything to do with treating the core symptoms of Tourette's is really that's bad news to a certain element of the Tourette's community. And the physicians that treated them. So there still is a group in neurology and psychiatry who are very much opposed to this idea or very much try to diminish the idea that behavior therapy should be used to treat the core symptoms. The newer neurologists, the newer psychiatrists, the newer generations of people with Tourette's, they're all for it. They love it. But there's a suspicion there that is still in some of the professional writings and some of the self-help writings. So we have to be very careful in how we sell this when we're going out and communicating. So when I talk to parent groups, for example, if you stay for the parent talk, you'll hear a completely different sounding sort of talk because I'll be talking about how environment doesn't cause the tics. It can just push the symptoms around a little bit. It can make the tics worse than they need to be, but it's definitely not the cause. I hit on that message because we can't let people think that we're saying that somehow early learning causes tics or something like that. We have to watch out for that bias that's already kind of latent there in the environment. We also have to be sensitive to this concern about negative effects of behavior therapy. I talked about a couple of them, but there are some other kind of concerns that are out there in the popular press, they're out there among people with Tourette's, and they're out there in the professional writings in some areas, that behavior therapy for Tourette's actually, it does more harm than good. And here are a couple beliefs that are out there about behavior therapy for Tourette's, that if you're going to start work in this area, you need to at least know how to address and know that there's data to support it. Rebound effects. This is the idea that comes from the statement of something like this. Yeah, behavior therapy, all that really does is teach tic suppression, and everybody knows that tic suppression, once you stop suppressing, creates a rebound in tics. So the more you try to stop your tics, once you stop stopping, your tics are going to flare up. So really, you're just wasting time. You're going to make them worse, actually, than had they never done behavior therapy. That's one idea. The other idea is this idea of something called symptom substitution, which is as old as behavior therapy itself, which is the idea that, oh, really, behavior therapy, all you're doing is pushing the tics around. So you stop one tic, but that just makes the other tics come out somewhere else. You know, it's kind of like whack-a-mole. You know, you hit one mole and two other heads pop up, and you're just chasing. That's all behavior therapy is. Okay? So if those are true, then we really need to know that, because we're wasting our time, and we're actually doing more harm than good because we're taking patients' money for nothing. So we tested this in a couple different studies. These are my favorite studies that we get to do, these experimental psychopathology studies. We tested the question of, is there a rebound effect? And this was published in Behavior Research and Therapy in 2006. It was a small study, as most of these are, because we don't have decades to get massive samples of kids with Tourette's in Milwaukee. We have 7 children with Tourette's. 3 conditions that we expose them to. A baseline condition. Well, let me set it up a little bit. A kid walks into my lab, and they're in a little observation room. There's a mirror that they think is a real mirror, but it's actually an observation mirror. And they're sitting in front of there's a table in the room and a little chair in front of them. On the table is a box that's about this high, and it's got a little camera on it. And they're told that that box with the camera on it is a tic detector. It can tell when they tic. It's got motion sensors in it that have been programmed to count their tics alone. Okay? And the kids believe this because we've just done a big interview, and it looks like we've been programming things and all this kind of stuff. So they're convinced that their tics are being counted by this movement detector. We tell them the tic detector will do different things, and we'll tell you what's going to happen when it happens. So the first thing we tell them is that we want you to sit in this room by yourself and tic if you need to tic. Don't try to stop your tics. The tic detector will count how many you have. That's baseline. We then, in the next condition, we say, okay, now the tic detector is still going to count your tics, but this time we want you to try to stop your tics. Sometimes the tic detector will tell them, we'll give them tokens if they stop. Sometimes it won't. They'll just be expected to stop. Okay. In this condition, what we asked them to do was, don't try to have your tics. Every 10 seconds you go without your tics, you'll get a token. The token will be exchanged for money at the end of treatment, at the end of the day. After that condition, we will go back to feel free to tic if you need to tic. The tic detector will count. No more tokens are coming. And here's what we did. So 7 kids on average. We had a baseline. They were ticking about 50% of 10-second intervals at baseline, ticking fairly frequently at baseline. When we put them on a DRO contingency, a differential reinforcement of zero rate behavior contingency, in other words, we were reinforcing them every 10 seconds they went without a tic, their tics dropped to about 15% of the intervals. These are 5-minute conditions, by the way. At that point, we said, okay, no more suppression. Don't try to stop your tics. Allow them to occur freely. No more tokens if you suppress. We don't want you to suppress. Following a successful suppression condition, which this was, if the rebound hypothesis is true, what should happen to the tic frequency? It should go up, and it should go up beyond baseline. A return to baseline is not a toxic effect of suppression. That's a return to baseline. A rebound as a toxic event is exacerbation past baseline. But that didn't happen. In fact, it didn't even get back up to baseline. When they suppress again, we replicated the condition. Do it again. They were able to suppress again. We tested rebound again, and it didn't occur. Now, the first time I talked about this in a actual talk, somebody said, yeah, but those were 5-minute conditions. Why don't you give them a real challenge and actually make them do it for like a whole class period? Then I bet your rebound will show up. So we actually tested that too. And what we did, we had 13 kids with Tourette's or chronic tic disorder, which is a fairly serious level of severity. This got published in the Journal of Abnormal Child. We had different durations of suppression. Every child got each duration of suppression, but the order in which they got that suppression was randomized. Right? So some children suppressed for 5 minutes first, some children suppressed for 25 minutes first, some children suppressed for 40 minutes first. And after each period of suppression, there was a 5-minute rebound evaluation phase where the child was told to tic freely, not try to stop their tics, no tokens given, and so on. And what you see here is that regardless of how long they were asked to suppress, they could do it. They didn't wear out. They kept suppressing, even up to 40 minutes in duration. You also saw that it didn't matter how long, this was not different than baseline. It didn't matter how long they suppressed, they never rebounded. Even after 40 consecutive minutes of suppression, they didn't have a rebound. This rebound effect hypothesis is wrong. There's no data to support it. And we've done other studies looking at this too. It doesn't exist. Now, one time I did this and somebody argued, well, what do they do after they leave the study room? What do they do after they leave your office and go to their car? Well, some researchers in the Netherlands studied that. They had kids suppressed for 2 straight hours and found no rebound effect after that, and then followed them home to see if they rebounded at home, and the answer was no. This rebound hypothesis is wrong. There's just no data to support it, and there's no data to argue that it's true. What about the symptom substitution hypothesis? This is the idea that if you stop one tic, it'll just make other ones worse. To study this, we did a single subject experimental design using a multiple baseline across subjects design while measuring multiple target behaviors so we could see the effects of one on the other. Published in the Journal of Applied Behavior Analysis in 2003. We had kids with Tourette's. We treated the vocal tics, but not the motor tics. Okay, we intentionally did that because our hypothesis was that if this is true, symptom substitution, as we bring vocal tics down, the motor tics should get worse. Okay, we pushed one down, the other one pops up. And we went in home to record. We had very depressed undergrads going out 2 to 3 times a week to the homes of these kids, setting up a camera and getting video samples, which undergrads just didn't like very much. I think they didn't want to be driving around the county, but that was too bad. They learned to like it, I guess. We had one 1-hour treatment session in which all vocal tics were treated, and 2 half-hour booster sessions in which we just reviewed the treatment. The treatment occurred in 2 hours of treatment time across 3 weeks. All we did was habit reversal. We didn't do everything else. This was just HRT. And this is a busy graph, but hopefully you're familiar with being able to read these. Each panel is a different child. The vertical dashed lines is the day of the 1-hour treatment session. Each data point is an in-home observation. The dark lines, the solid lines, are the vocal tics. The dashed lines are the motor tics. Okay. So if we look at Don, significant reduction in vocal tics almost immediately after treatment started and a maintenance at 3 months later. I think that was a 3-month follow-up. His motor tics that weren't targeted for treatment also decreased and maintained 3 months later. John, significant decrease in his vocal tics, no change in his motor tics. He relapsed at 3 months. Ben, significant reduction in vocal tics, no change in motor tics, maintenance at 3 months. Raul, reduction in vocal tics, no change in motor tics, maintenance at 3 months. Frank, no change at all from treatment in either tic. So what does this tell us? This tells us that the symptoms that were targeted for treatment in most cases decreased. The symptoms that weren't targeted for treatment did not increase, but rather, if anything, decreased. Most of them didn't change. In fact, if we summarize the data, what we find is that the tics that were targeted were vocal tics. We saw an 83% reduction from pre to post treatment across the subjects for the vocal tics, and a 26% reduction in the untreated motor tics, which argue strongly against this concept of symptom substitution. It really doesn't seem to happen. Okay. So, summary and future directions. HRT, behavior therapy, CBIT, is a promising treatment for Tourette's. We still need to get the large-scale study for adults at least published. Like I said, the child one came out in JAMA. The adult one is very positive, and we're going to submit it in the next probably week or two. We still need data on predictors of response to treatment. So what do we know about predictors of response to treatment? From the child study, what we know is this, that I don't think it's quite significant, but it looks pretty close, that ADHD causes a problem for kids with Tourette's in terms of responding to this treatment. If you have ADHD, you're not going to do quite as well on this treatment, which tells you something about treatment sequencing. If you've got a kid with ADHD and Tourette's, get their ADHD managed effectively before they start into Tourette's treatment. Now, why is that ADHD thing there? My guess is it has more to do with compliance issues than it does with anything else. I think it's more of these kids don't do the homework assignments we ask them to do. They don't follow through on the homework assignments we ask them to do, and so on. I think it's more that issue in ADHD than any other issue. OCD doesn't seem to make a difference, although clinically my own impression is that OCD probably helps you respond better than anything else. That's just clinically what I find. If you have OCD, you actually tend to do a little bit better on this treatment because it's a really rule-governed treatment, and that's kind of your thing. If you have OCD, you like rules and like following them, so it kind of fits in. Other anxiety disorders really don't seem to affect outcome, so it doesn't really seem to really impact broadly beyond other conditions. Don't seem to really impact outcome very much. In terms of long-term maintenance data, we have 6-month data. It would be nice to get out there a year, 2 years to see what happens. It'd be interesting to try looking at prevention models. So if we start treating kids when their tics first show up, do we end up preventing the development of Tourette's later on? That's an interesting question. We need to have behavioral and neural mechanism of change data. So what do we know from neurology in terms of pre-post imaging studies, pre-post EEG studies? We do know that there are changes. Now, I hope we're past the point of being surprised that if a treatment works and brain changes around that occur, that we're not surprised anymore. Of course, if you're behaving differently, your brain is functioning differently. But there is some evidence coming out of Montreal, from a psychologist named Kieran O'Connor, showing that there are some pretty noticeable EEG changes in frontal lobe areas following successful behavior therapy for Tourette's. And there's some imaging data I've heard about that really suggests the same kind of thing. And I can't talk much more about it than that. We also have to think about overcoming these barriers to implementation, usable manuals, which we've developed. One of the things we've been doing in my lab is really focusing on telehealth service delivery. So telehealth is being used across a lot of different domains in psychiatry now. But Tourette's, there's a potential, especially when you see later in the afternoon for the way we do treatment, there's a potential problem with doing it over like video conferencing equipment or Skype or something like that, just because of the interactive nature of the intervention. But we've been testing this in my lab, and we've done a pilot study that came out in Cognitive Behavioral Practice in 2010, I think, with 3 kids in a single subject experimental design, and it showed that there was some utility in the treatment. We treated kids who were sitting in North Dakota. We treated them in Milwaukee over video conference equipment. It seemed to work really well. And then we just wrapped up a head-to-head comparison of face-to-face versus telehealth delivered versions of CBIT, and what the results look like are really good. They look overlapping, so there is no difference. You can't tell the difference in efficacy between doing it face-to-face versus doing it over video conference equipment. And in my clinic, I have my therapists are now treating distant in-state patients using Skype because it's got good enough encryption technology to use, and we've been having really good success with that as well. So that could actually revolutionize the way we would deliver this treatment, because one of the big problems with this intervention is that nobody knows how to do it and nobody's trained in it. And with a disorder like Tourette's, there's this perception that there's not enough patient flow to actually make it worth your while as a clinician to really learn the intervention and become the expert, because you couldn't fill your patient calendar with it. With the Skype model, what you end up being able potentially to do is to have one psychologist in a state that is that person, and they become the provider who delivers the treatment in-home over the internet to everybody. That becomes the service provider. So we're excited about the telehealth possibilities. And so we're doing a lot of education and talking about developing computerized therapist training packages and so on to try to get this stuff out to more people.